requesting the moderators. Yeah.
So without wasting much time, we'll start the session as already we are running late. I'll request all the presenters to curtail their talk by at least 3 or 4 minutes so that we can. So in the end, it is all about money, as they say. So India is beyond statement. For anything you say, the opposite is also. It is rich and poor, spiritual and material, cruel and kind, angry but peaceful, ugly and beautiful, and smart but stupid. It is all in the extremes. What works in Kerala does not work in Bihar. Still, we have to run a program of pediatric cardiac sciences everywhere. So where will the money come from? Do we have a single model for all this? So, am I audible now? So where will the money come from? So without wasting time, I'll invite the first speaker, Dr. Arun Singh, to speak on a critical appraisal of RPSK program from the national perspective. Dr. Arun Singh. Dr. Singh is National Advisor, Rashtriya Bal Swasthya Karyakram, Ministry of Health and Family Welfare.
Just to move the slides up, just to move the slides up, use the laser.
Okay. Very good morning to everybody, and thank you for inviting me. Tomorrow, that is 13th of October, is the birthday of a very famous person called Rudolf Virchow. He had studied in Berlin. What was very interesting, that as early as 1898, he got constructed a hospital for 2,000 patients with 1,000 faculty staying within the campus, and you can see the photograph. And some of the things which he said is very relevant to RBSK. Because in 2013, when Government of India thought of starting a program for children, the main question is, what is the philosophy? You are already doing there is a pediatric ward, pediatric department. What is new for RBSK? So I think the main challenge of RBSK was science and equity, deliver to the last person. And I will keep on talking to you in a critical way. Could we go to the last person at all? And as Virchow said, the physicians surely are the natural advocates of the poor, and the social problem largely falls within their scope. The second comment is far more relevant today because medical education does not exist to provide students with a way of making a living, but to ensure the health of the community. In today's world, when can somebody help? It's not moving. So in today's world, when everything is so busy, all of you are so busy, have we forgotten the child? And when I say the child, it starts from fetus. Child and nature were coexisting. Life is a marathon, not a sprint. So this is the second thing we remembered in RBSK, that overnight we can't do any change. We must reflect. And that's not a privilege, it's a must. So there were 4 principles which we talked of. evaluate what we are doing, what we have accomplished, celebrate what we have, our victories, learn from the mistakes, and chart out the future direction. And I quote what Bhagat Singh always said, that ideas are far more important than action, so RBSK has to have a very powerful idea. And the idea was, the fire of my ideas will remain in the air. This life is a handful of dust, no matter if it remains or not remains. So what were the problems identified? The first thing is, whenever you are poor and marginalized, you have no papers. So we say this program is meant for below poverty line. Where are your papers? You go to any tribal, he will have hardly any papers. So the first principle we said, poor people are not only poor in terms of money, but also in terms of what their rights are. Second, in a pediatric OPD, how much time do we give to a child? It's almost 10 minutes. So in 10 minutes, if we go for an organ-specific approach, then if I am a cardiologist, I'll only look at his heart. If I'm a nephrologist, I'll look at his kidney. Who looks at the child as a whole? And how do we begin the question? We begin, what's the problem of your child? Why have you come? Now imagine in a busy OPD, when you ask a mother, you take it for granted that she is half doctor. She knows the problem of the child. And in a country where education is so much different and there are dogmas, how do you expect a mother to tell exactly what's the problem of the child? So she only tells what she perceives, and what she perceives may not be the truth. So it was organs, and then you look at the programs. The whole program is blindness control program. So somebody is going to look at the eyes. Deafness control program, somebody is going to look at the ears. Iodine supplementation program. How will these programs converge on the child? If this child comes to you, do you have enough time to see him, or do you want to keep on referring him from one program to another? So how to integrate? Second thing is, the entire life of child, which is birth to 18 years, is not the same. There are certain critical periods of his child, critical periods of brain development. Are we missing on those periods? Just because the child is non-verbal, are we missing on that critical period? Then, our entire medical science mostly assesses in a physical way, physical examination. But what about his functional? So eyes are okay, but he cannot see. There's a difference between eye and vision. For a vision problem, if you refer it to an ophthalmologist, he will just write a note, everything is normal, yet the child cannot see. So where is the evidence? We consider evidence as what is published. We don't consider evidence as what is practiced. And a difference between preventing a disability and the difference between rehabilitating a disability. We have most of the programs in rehabilitating a disability, but what about preventing a disability? So with these questions, some 40 disorders under 4 Ds were selected. We found that for the same child, you could have a defect of birth, so you can have a child with congenital heart disease. The same child may have vision problem. The same child may have developmental delay. The same child may have deficiency. Now, if you treat him in parts, then you can say, as a cardiologist, I did a great job, but the child still cannot go to a normal school. The child still cannot become one of you sitting in this hall. So what is our goal? Is the goal to correct an organ, or is the goal to enable that whatever genetic potential we have, we should be able to achieve it? So that was a question, and we started making that screening is for generalist, management is by specialist. We said, don't waste your resources of a clinician trying to screen. And when you are a screener, you are not an organ-specific person. So earlier in school health, we had dentists only seeing to the dental care of the child. We said, no. let the dentist treat, but a screener should be able to screen from head to toe. And that could be anyone in the medical science. The least the doctor, because doctors are more trained to treat. So let us utilize their resources for treating. So 11,000 teams were made of 4 people. None of them were MBBS doctors. We didn't allow Ayush practice, but we said let the Ayush doctor agree that this is a heart disease. That's all. Once they refer it, let it be managed scientifically. But for screening, he will screen from head to toe. So we came up with this. We came up with this pictorial. We said eyes can be seen even by a class 8 student. And remember, one of the biggest learning is that we didn't require an ophthalmologist or an optometrist to screen. Just with a pictorial tool, eye is a game of 3 circles, and most of the children could identify a problem. And our main problem and challenge is, I can identify a cataract in a 1-year-old child. I can identify a cataract in newborn. Where is it going to be operated? So that's the level 2. But now at least we are coming up with this. So the concept was not survival, but healthy survival. We are Homo sapien, let us have. And so it started from birth and even before birth. These were the publications, and then this was the entire country. This was, as you can see, in millions, the number of children screened. Some people say, Dr. Singh, you are showing that these are screened. What's the quality? Now let me tell you, at least you have put the fishing net in the sea. What you are picking up is what is important. So this program didn't stop with screening. It went for referral, it went for management, the monies were being there, and I will quickly show you that it started again at birth. All the institutional delivery needs to be screened for visible, for functional, for heart. This was the poster which was created to be put at all the delivery points, and this was the functional book. So you can see even a newborn eye screening, not only ROP, and this was the results. We are yet too short, but this was a great beginning. There were some institutions which was developed under this. We want the public sector capacity to improve. This is what was the result, and confirmed, medically, surgically treated. But I think that at least, I was earlier a professor, I came on deputation to this program. At least I can vouch as a neonatologist, we were not able to even screen and identify them as early as this was being coming. The blood screening was there. This is some of the program which funded for developing exclusive cardiac OT for children, ICU. And it has to be there with this. And these are some of the things which came out. You'll be surprised as there were villages where every child was, majority of the children were born as anophthalmos, that means no eye. And then when we understood, we found this, which was not reported. So these were some of the things you can see the case reported. These are the number of birth defects. Now what is there that we said birth defects could be visual, functional, metabolic, neurological, and it has to be geotagged and managed. This is DIC. One of the biggest fault is you are saving children, but you are not assuring within the pediatric department that each of his organ is functionally evaluated. I am a great surgeon, I operated on a heart, but what about his cognitive? What about his vision? What about his hearing? Are there tools to identify the vision of a pre-verbal child? And this was the huge challenge. So these DICs was made, and it was made like a primary school teacher. So you can see that the dental chair was designed in our country, which looks like a car, because children would not go there. So there was a great association between dentistry and heart disease, and we could see that. So these are some of the photographs of the DICs which have been built, the vision screening, the hearing screening, the cognitive screening, and this starts in the newborn. You have seen this. Then came, can we prevent some of the birth defects? What are the messages which have not been told? So I think the time is over, but just to tell you that the fetuses have all the emotions which you and I have. And so a program was made, and I can take RBSK as a very important achievement was learning from the society. So one of the things which learned was don't cut the cord till the placenta is delivered. This work was published in American Journal of Perinatology, and this was found to have immense benefit in terms of 100 ml of extra blood, 45 milligram of iron, oxygen going more, and cardiac, a smooth transition, which was what it was due. All animals, never you cut the cord till the placenta is delivered. So this was there. Sorry, I think it's over, but some of the developmental tools which have been developed in RBSK, and the most important period of life is not the age of university studies, but the first one, the period from birth to age of 6. And from birth to 6, it is the first 2 years. So I said, yes, civilization is developing. We are reaching the moon, but have we moved away from our dogmas? Dogmas to identify, dogmas to treat. Have we reached the last person? Thank you very much.
Thank you very much, Dr. Arun Singh. And I can say that RBSK is actually health revolution in itself. And I have worked with him and RBSK program very closely. And it has been so wonderful, and definitely the multiple aspect has been covered. So I think it was a very successful attempt. Thank you very much, sir.
May I invite Dr. Shri Hari M for the next presentation. He is the State Nodal Officer from Office of the Mission Director, National Health Mission, Trivandrum.
This is the presenter, sir. You can use this to just answer.
The RBSK program, because I was working in Madhya Pradesh, primarily my program was Spandan, where we selected patient for the from the pediatric cardio angle. And then subsequently we found that there may be Down syndrome, there might be multiple this thing. And then RBSK has the all wholesome approach towards these kids. I think it was a wonderful beginning. Thank you. Yeah. Okay.
Good morning, all. Thank you for the invitation and a chance to present it before the audience here. I'll be telling a story that we did or we come across in the last 2 years. So as everybody knows, India has achieved a lot of things in the last 2 decades, especially with regard to IMR. We were able to reduce the infant mortality rate around 54% in the last 2 decades. But look at the Kerala graph, we were stagnant at around an IMR of 12 for almost 2 decades. And all those time we were the best performer in the country. Fortunately, we were able to reduce the figure by 2 points in 2016. But in 2013 itself, we started discussing, trying to find out some reasons for it. With the support of Indian Academy of Pediatrics, we did a retrospective analysis of the data 2013, the mortality data collected by the health department. And we found that congenital anomalies are contributing a lot along with the prematurity. So this point we identified the epidemiological transition is the troublemaker for us, and we have already achieved almost, we have plucked almost all the low-hanging fruits. The state, the same thing that we can see, or it is in a much aggravated fashion, which is happening in 2018-19 also. So the state decided to look at in a particular fashion, especially in the context of SDG targets that we have set up for 2020. The target is IMR reduction to 8, and 2030 for a target, very ambitious target of 6 that we are trying for. So in this context, with the support of Children's Heart Link USA, we did a status analysis of 2016. What is the available systems in Kerala to look at the congenital heart disease as a problem or for a solution. So in a population of 33 million with a 500,000 birth cohort, we had to focus on around 1,400 cases to be operated in the infancy. And we were doing around 500 cases at that time, especially the infant cases we took, there is only 500 cases. So we found that we are very fortunate to have almost 7 operating units in the state with definitely one of the best centers like Sri Chitra in the public sector. So again, looking at all these things, we developed a patient care continuum, which starts from case recognition till the treatment and follow-up. So this is again, we did with the support of Children Heart Link. Opportunities and barriers were identified, and all these things were used for the planning for next 5 years. So we have a target by 2023. We put forth everything from 2017 onwards. So we started a program. We made a system ready in 2017. So before that, this was the milestones that Kerala has passed across for with regard to congenital heart disease care. So till 2019, it was only the public funding program was only with Sri Chitra, and 2009 the state initiative called Talolam has come up. 2014, of course, the RBSK that we heard last session from Dr. Arun Singh, we started RBSK program. 2014-15, we tried the private empanelment with Amrita Institute of Medical Sciences, Cochin. And 2017, in a big fashion, a system is built called Hridyam. So it has 6 pillars, starting from the case registration. DAs is the key point. Pediatric cardiologists are the real opinion makers and the decision makers. Everything is based on the prioritizing the cases, because we have limited resources, limited slots for doing surgeries or interventions. We need to prioritize the cases. We have so many cases. So we have around 4,000 cases, and we need to do 1,400 cases where we were doing 500 cases. So the pediatric cardiologists were the key opinion makers. Public hospitals definitely is a major pillar, and the Hridyam admin and empanel hospitals. So there is a patient flow when the case registered that will come to a web-based platform. Hridyam.in is a platform where the cases can be registered from anywhere, any neonatal care unit, any pediatrician, anybody from the public can register the case. It will give some alerts to the DAC. DAC will verify whether all the parameters are available. So we'll look for certain parameters which should be available, the clinical information, the medical information, documents. So all these things will be reviewed by a pediatric cardiologist and gives an opinion, which is the categorization. Categorization is mainly done for when that to be operated. So we have different categories, category 1, 2, 3, and 1A. 1 is divided into 1A to F. So 1A means that needs to be operated in the next 24 hours, 1B in next 48 to 72 hours. So that way we have categorized cases, and there are guidelines developed, which is being shared to these pediatric cardiologists. Also, we take opinion, expert opinion from other pediatric cardiologists available in the state. So the case once categorized, it will go to the public hospital. If you get a chance to get operated there, there is a big waiting list, backlog with regard to the public hospitals. So if the slots are not available, automatically the cases will be referred to the all empanel 5 the private hospitals. So the private hospitals will give dates, and that date, if suitable for the family, and which is the earliest date, that will be counseled with the family by the DAC, and consent will be taken from the family that will be attached, and the information comes to the admin, and admin allows the case to the hospital, whichever the family prefers to. So, and we take care of some of the aspects like the geography. We don't want to take the baby from the northern part to the southern part. So we consider many things, and based on the consent, we'll send them to the private hospital, and the surgery is done. Then the follow-up is done through the DAC and the RBSK nurses in the system. So you can see the numbers, some of the numbers already by this year, we have around more than 2,000 cases. Every month, we have around 250 cases being registered. So we focus mainly on And this is the case profile. You can see a timer is going that says 5 days and 33 minutes 9 seconds for this child to get operated. So there are alerts and alarms going on for a diagnosis. We get expert opinion from clinicians. Case is allocated, that is available. These are the five information the things that we need. So this is the things that we have done from 2017 August. 2017 August we started the program. So you can see there is a improvement in doing the number of cases. 2017 we not consider. 2018 whole year and 2019 till the third quarter we did more than 100 cases more than the last year. And this clustering is the one that we are looking at, 0 to 1 year. We are operating more children from 0 to 1 year than any other group because we focus on the IMR reduction. So we integrated the screening programs as part of the RBSK. We started doing the pulse oximetry in 24 to 48 hours in all public health institutions. The entire process is automated. Once the baby is screened, the information will be going directly to the server. The system will give some alerts. This child is having control, so the pulse oximetry is failed. So we are trying to integrate this thing with the physical examination so that we have better results. So this is the pulse oximetry screening program that we are doing across the state. Now we have moved from the 56 institution, the initial phase, to all 98 delivery points in the center, in the state. So now we are focusing more on improving the specificity of the pulse oximetry program, which usually everybody says it's 50 to 60%. Now we are integrating physical examination. And again, we are trying to take some of the technology advances in the field available. So we would like to do the screening again by the nurses only. And this is another initiative we did along with this. Hridyam is an e-learning platform where the sensitization of pediatricians and obstetricians is the major pillar that we are looking at. So we are doing a learning program. So these are some of the challenges that everybody knows and everybody talks about. We don't have a transportation system. We are trying to develop one, dealing with complex diseases in certain situations, capacity building in public sector. Then, of course, Dr. Arun Singh has mentioned about the neurodevelopment. We are doing certain things in this. So the most important thing is the uniqueness, the first of this kind, a comprehensive approach to congenital heart disease in the country. Of course, it's a cashless, it's a web-based registry is available so that we have some data retrievable. We can do the analysis and say things, what to do next. It is helpful for the administration for planning. Main focus is early diagnosis, and the beautiful thing is the entire surgical slot in the Kerala is made into a single pool. So that is the most important thing. We have we got the state awards on certain things. I'm not going to the video. I just skip it. This is the ad that we use in the media for promotion and sensitization of people. Thank you.
Thank you, Dr. Srihari. Kerala has been a leader in public health, and we are looking forward to your leadership in Hridyam. It is Karuna Hridyam.
Thank you.
So, 1 minute, sir.
1 minute. Only I just wanted to know that pulse oximeter you have used mostly. So you are also attending the critical cardiac diseases. What about the second and third intervention, and when the process is required, how you get funding for that?
Pardon, madam. Second and third processes means?
Second, third, like if you are dealing with the complex congenital heart diseases
Okay.
also,
Yeah.
so you may need second or third intervention within a year or two. So how you are getting funding for that?
2017 itself, the state has taken a decision that we are doing this not for doing a congenital heart disease program. We are doing it for infant mortality reduction. And for the motto of RBSK is healthy survival. So we decided if funds are not available from the RBSK program, the state will take care of this. And we with the support of the senior pediatric cardiologists in the state, like Dr. Suresh, Dr. Krishna Kumar, we are debating, and we have come up on a consensus that the state will identify the funds for it, and there are two separate categories we have developed for other than the 19 procedures under RBSK. We take all cases under other than RBSK, open heart and closed heart. So we take care of almost all the conditions right now. Thank you.
So they used to say what Bengal thinks today, the rest of India thinks tomorrow. I think we will have to change it little and say that what Kerala does today, the rest of India will have to do tomorrow. And for all those who are interested in the Kerala health model, there's a nice film called, feature film called Virus in Malayalam, and how they contained the Nipah virus attack within no time. And it is available on Netflix or Amazon or wherever, I think. So we'll move on to the next talk. Dr. Milon, he'll be speaking on making the most of resources, human and material.
Please to move the slides up. Okay, so you can move it further, move it down, and then you'll get a laser.
Thank you for inviting me to come and share what has been on my heart for about 20 years. It was in December of 2000 that I first went to Mongolia to help screen children with heart disease in a country that had never had an echocardiogram. And so I am at a disadvantage because I've never treated and been involved in the medical work in India. But I'll share with you what I see around the world, and that'll be mostly from things I've seen in Mongolia, Iraq, Papua New Guinea, Zambia, and other African countries, including Sudan and Malawi. I think it's always good to share what our biases are before we talk, so you know where I'm coming from. My bias is that I have a profound desire to help those in need, to love one another, and that pride is a dangerous enemy, and that comes from my Christian faith. The next is that I try my best to learn from others' mistakes. I think this is basic wisdom. I think this is why we have these conferences, so we can learn from others' mistakes. We all know that pediatric heart care is built on the foundation of dead children, and I would like to have a few less dead children. We have great masters here who have showed us the hard road to make dramatic changes, like Dr. Nakaido. And so I think if we can learn from our mistakes, that's very important. The last thing is I try not to make my patients worse. And that sounds basic until you get excited because you have a new procedure or you have a new opportunity that would make you famous in your country or famous in your hospital. But that might not be the best thing for our patient. And so once again, we are servants to our patients, and taking care of children is a sacred honor. So there are two different ways to look at the resources. There are limited resources, and then there is the poor use of resources. Limited resources is basically the budget does not allow for the medical care that is needed. That's very common around the world. It's actually very rare to find a country that doesn't have this problem, but it's just to differing degrees. Then there's what's worse, much worse than limited resources, is the poor use of resources. And this is copying others who are further in their development with priorities that have become dissociated with pragmatism. Unfortunately, what happens is the poor use of resources leads to limited resources. And that's actually what I see most around the world, is there is some funding from the government that could make a dramatic impact on a number of children's lives. But because it is used poorly, then that intended impact is lost. So let me show you, I was in Iraq, and let me show you what I found. There's a machine that will put your shoe booty on. Well, that's a pretty fun thing to have in the cardiac hospital. Unfortunately, they had the shoe thing, but they lacked a pediatric pulse ox. You guys laugh because you know what I'm talking about. Often the government or the administration buys something for your hospital, and you know what? I can show you the data that actually the shoe booty does nothing to improve patient care. But a pediatric pulse ox would have a dramatic impact. Now, this is also in a different portion of the Middle East. So the question is do we spend money on a warming blanket, or do we spend money on a multicolored LED OR lights? Well, because the administration decided to buy these incredibly fancy LED lights that were somehow going to be able to help a surgeon see blood better and see it on the drapes, they decided not to buy anything to warm an infant or a baby, and then we're wondering why they had poor incomes of children. It was very simple. When we come in there, they almost always ask our team to come in to explain, why do you do so well with children under 15 kilos or under 10 kilos? It's because we care for them. And as all of us know, what is the most important thing, especially for the newborn, is heat stress. And that's not thought of at all. I've had to resuscitate a baby with tea wrapped in latex gloves because we had a child who had gotten so cold during the operative procedure because we had no way to warn them that he now had become coagulopathic and we could not get the bleeding to stop from his puncture. What about, this is now in Mongolia. Now what about a proper anesthesia machine with Untitled CO2, with expired gases, with proper inhaled gases? Or we could get automatic doors. I've been to places that had beautiful automatic doors, but they were using 20-year-old anesthesia machines. What about a full complement of cardiac drugs? Or catheters and devices in numbers and sizes never to be fully used? I open up the closets bought by the central government of countries that are desperate for resources, and I see all of these devices that they will never use. I open up a cabinet and probably saw over 100 VSD devices in a cath lab that no one is qualified to put in a VSD device, but they were very happy they had them because they had more than everyone else. They have hundreds of adult catheters that will never be used by children and will never be used by anyone else. They will expire with never being opened. But often it's really hard when I go to different countries. We've started bringing a number of our drugs that we need because it's really hard to find phenylephrine. And I would trade all of those VSD devices for one vial of phenylephrine in the ICU, in the operating room. And I want to say this because I know this is a very difficult thing, but here we are advocating for children, and I think it needs to be said that there's a time to share with the adults, and then there's a time to have supplies that are dedicated to the care of children and are not the leftover from what the adults ordered. But that's often what we find ourselves doing, is we're using the leftovers from the adults. There are lots of reasons for this. In the United States, we say it's because children can't vote. And so what drives it are those who vote. Also in other countries, I would say that children aren't in parliament. In many countries, it would be better if we had children in parliament, but we don't. And so they have no voice often. So we are the ones who have to be their voice. And us as advocates for children need to engage the political process and to be involved in decision-making for the non-consumables and consumables for the cardiac care of children. I really don't like meetings. I don't like administrative processes. It seems to me like an enormous waste of time when there are children who need to be seen. And I think for a lot of reasons, a lot of us feel that way, so we have left those decisions to other people. And then they get us doors that we don't need, lights that we don't need, and all the things we really do need. We were not at the table to advocate for our patients. I like what Solomon once said in the Hebrew Bible. He said, "Open your mouth for the mute for the rights of all the unfortunate. Open your mouth, judge righteously, and defend the rights of the afflicted and needy. As pediatric care providers, we are the voice for the afflicted and needy. So as we look at material resources, I think we need to say that as much as we can be frugal with your limited resources, we still run out. And I like to do as much as I can with U.S. trash. So when the evaluators of hospitals came in through the United States recently, what they've done is made everyone afraid of anything that's going to expire within 6 months. Plastic that's going to expire, metal that's going to... I'm not talking about drugs. I'm talking about bulb syringes, have an expiration date on them, which bulb syringes, you know, could save thousands of lives in places where you don't have a bulb syringe during birth. But so I like to gather this stuff up and take it and help. Let me give you a case in point. For a child born with detransposition of the great arteries in Kosovo, he had low SATs and a very small PFO. The doctor there had two options. He had a Rashkin catheter that he had used 7 times and re-sterilized each time with Cydex. And he could use that single-use Rashkin balloon for the 7th time after liquid sterilization, or he could follow U.S. guidelines and let the children die because you are not allowed to reuse a single-use catheter. I'm glad that there are people in Kosovo and Iraq and Mongolia who don't always follow the labels. So I guess you'll see where I am on the debate on reusing things. What I would like to say, though, is I think when we're reusing things, just make a note in the chart so you know. Because we need to study basic inflammatory infectious parameters if they're reusing supplies. I have a sense often that when we're reusing catheters in the cath lab around the world, I see a little bit of an increase in post-procedure fever. I think there's something, even though we can wash it and we can re-sterilize it, there's something still left. And I like to draw your attention to lipoprotein A. It must be cleaned away. It cannot be sterilized away. You can sterilize a catheter all you want. If it has lipoprotein A on it, it will still be a potent initiator of the inflammatory cascade. But when faced with a child who's in a grave situation, I would much rather try to treat an infection than death. Material supplies is a complex topic and brings in human resources as well. And I love some of the debates that we're having here. I've been longing for these debates. I go to international conferences all the time, and where thousands of children are dying, we're still trying to talk about the developmental aspects of a single ventricle, when we're not caring for basic children with basic shunting lesions that they're dying of. And so, but when I talk to you about this, specifically with Dr. Suresh Rao's talk yesterday about how to train a surgeon, what do surgeons need to train on? PDAs, ASDs, VSDs. So how do we close an ASD? How do we close a PDA? How do we close a VSD? What to use for our RV to PA conduit? If we have an ASD, do we use a device or we do it surgically? If we close a PDA, do we use a device or we do it surgically? How much is suture versus a device? I know, the interventionists go, well, it's really about the same. But if I were going out to go shopping, I think I would rather buy 6-0-Proline than I would to buy an Amplatzer device. How to close a VSD, is it surgery or a device? What to use for our RV to PA conduit? Dr. Fatoon is going to present a very interesting paper where in places where you can't always get a Contegra, they started making their own. Here, they've started making their own. What a beautiful way. Saves probably a couple $1,000s. This is what we need. There's a need, so we figure out a way to get past it. What can your situation afford? Devices and left to right shunts. Okay? Do we use devices and left to right shunts? These are my views on things because I think this is a discussion we have to have. Because the cardiologists, I'm a cardiologist, we can steal everything from the surgeons, then we're upset that they can't fix a basic cohort. Well, we'll do that anyway. We'll take care of that as well. Surgery, it's a building block of surgical training. All of these things that the cardiologists are starting to take away. The advantages, there's no concern for a loss of device if you're a surgeon. I don't think a surgeon has ever called an interventionalist asking for help because they lost something. No interventionalist does not need to be around. The surgeon gets to be the hero. The disadvantages, it's invasive and it has significant ICU time. Outcomes, pretty similar. Interventionalists don't need a surgical team, the way of the future. That can be debated whether you need a surgical team. If you lose a device, you'd be very happy if you had a surgical team. Advantages, much less invasive. The parents love this. Usually no ICU stay, they discharge the next day. The cardiologist gets to be the hero. Disadvantages, it may erode or become displaced. We don't know. We haven't been studying it for 20 or 30 years, have we? Interfered with the development of the surgeon. It might be nice for the short term, but you might have just ruined surgical training. And you really should have surgical backup. Native coarctation repair versus balloon. The surgeon, it's a non-pump case. It's good for them to learn it. I wish I would have surgeons who would be willing to do this in developing countries. Properly chosen cases yield very good results, helps with speed and precision of the surgeon, less chance of recoarctation. It's preferred in the largest centers in the West, still preferred. If we're talking about helping human resources, this has to be included in our equation. Interventionalist requires good selection of balloons and or stents or covered and or bare. Available where neonatal surgery is not. This is a wonderful thing when you have a child crashing. And it's even sometimes a nice bridge if you have a child crashing to give them a little blood flow so they can do surgical repair. May recoarct, may need additional procedures. But it takes a good surgery away from those who are losing many of their surgeries. Okay? So I'm just putting these are good topics to have debated. There should be much passion about this on the sides, but it needs to be debated because it's part of our human resource part. Human resources, everyone needs to be trained. I love the talk from Heartlink. I'm sorry, I forgot the name, but I love the talk because it talked about all the resources that are involved. Who largely gets trained? It's the surgeons and the cardiologists. We might feel inclusive and bring some anesthesiologists, intensivists, and perfusionists, but it's usually the cardiologists and surgeons are getting most trained. And then we're upset because people die in the ICU. Did you send them to any conferences? Did you get any specialized training for them? Did they get to go on any of the international junkets that we get to go on? Rarely. When we do cardiac missions, we usually have a one-to-one, nurses to nurses, pharmacists to pharmacists, perfusionists to perfusionists. So when we were teaching Mongolia, when we went over to Mongolia, they were doing ice surgery with ether anesthesia. And this was in 2005. Okay? But we would take this big team, so we could fully staff an ICU, and every one of our team had a Mongolian counterpoint to train. But that meant we were training nurses who weren't sure in Mongolia whether they needed stethoscopes or not. Cardiologists, surgeons, intensivists, anesthesiologists, perfusionists, and ancillary personnel. You might not think that's not that important until 2 a.m. you need an X-ray stat in the ICU. Then ancillary personnel suddenly become quite important, and you realize that they went home at 5 o'clock because they've rarely been needed. Human resources impacting surgeries and interventions. There is a real lack of appreciation of the role of the anesthesiologist and the perfusionist play in the success of pediatric cardiac surgery. You do not just grab any anesthesiologist off to do your surgeries. If we don't have proper anesthesia when we come, I have different levels of cardiac anesthesia training on my teams. There are some cases I won't do the procedure unless I have the best anesthesiologist to get us through that procedure. These are not interchangeable, and many of these cases we could just put them off for a week or a month and have a better outcome. Lack of appreciation of the importance of the ICU. This is probably what I see internationally most. It's not an appreciation of all the knowledge an ICU doctor has. You know, surgeons, we're happy for you just to be surgeons. I don't want you to stay up all day working in the OR and then have to be up all night taking care of the patient. I would rather you to keep operating. There's a huge number of kids who need operations. I don't need you tired from the ICU. And I would say most surgeons don't know all the complex ventilatory mechanisms we use currently for our really sick heart kids. Give that to somebody else. And if we could just keep bedside nurses at the bedside. Let's keep them there somehow. Let's not run them off. And one of the ways of not running off our ancillary personnel is by success. People love success. People hate being around dying children. If you don't set up your team to have success, you will drive them off, because there is nothing more painful than being there when a child dies. The scream of the mother, I have screams of mothers in my brain. It's those sounds I never want to hear again. Also, you can think you do a great job surgically, a great job ICU, and then you call up and you go, what about the blood bank? What we found is that warm, whole blood is a godsend and incredibly life-saving. In fact, you know, we've used it a couple of times because we didn't have it, we needed it right away. Oh my gosh, it works like magic. It's got platelets and plasma and red blood cells. It has all the good stuff. It hasn't been stored. We don't always use that, but boy, when you need it, it's there. So I would encourage people to look at the deficiencies in all areas: human resources, material resources, hard resources, consumable resources, and ask visiting teams to help. You don't need them to come and do stuff you already do well. Maybe your surgeon is great. What you really need is an ICU team. You don't need a surgical team. You just need an ICU team. Maybe you really need a much better imaging cardiologist. Invite a cardiologist to come. Maybe you have no TE support. Do that. You don't have to bring in the whole team. Figure out where your weaknesses are and ask for that help. The Bible says, he who finds a wife finds a good thing and obtains favor from the Lord. Well, my wife is a pediatric cardiac anesthesiologist. She is a lovely woman, the love of my life. I've been married to her for 22 years. And for most cardiologists and surgeons, boy, if you could have your own anesthesiologist who loved you and stayed with you for 22 years, you would have found a good thing. The reason I've been able to do so many things over the last 22 years is because she's been at my side, and she would go with me all the way to Fallujah when we were locked in the hospital the whole time, and we had guns going down the hallways trying to protect us. And I want to end with my favorite quote. It's from Charles Dickens. It is no small thing when those who are so fresh from God love us. Thank you very much.
Thank you, Kirk. It was a wonderful and emotional speech, I would say. I'm sure Dr. Iyer and Dr. Parvati Iyer would agree with what you said about having a husband-wife team. But maybe they may have a plaque at home and saying that I'm the boss in this house and I have my wife's permission to say so. So thank you very much. And moving on to the next talk.
So I would like to recall Dr. Arun Singh. The cardiac care system is not a sprint but a marathon. So I should call Mr. Srivasan. I know him. He is involved with the Genesis Foundation, and he knows what is the importance of a marathon in the cardiac care system. So Mr. Srivasan. Okay.
This one is the forward. Good morning, everyone. Thank you for inviting me for giving the small presentation on funding of pediatric cardiac surgery in charitable institutions. So So Genesis Foundation is based out of Gurgaon near Delhi. It was started in the year 2001. The founder trustees Prema Sagar and Jyoti Sagar lost their second son due to congenital heart defect about 30 years. At that time, congenital heart defect was very infancy in India. When we started, we were focusing on pediatric cardiology, cancer, and thalassemia. But for the past 2 years, our focus has been only on pediatric cardiology. So far, we have supported 2,300 children. Our support is for families whose monthly family income is less than 10,000 rupees or $150. I would not like to dwell into this number of cardiac cases in India. It's well known. This slide basically represents the pan-India network we are having. So far, we have partnership with 25 hospitals throughout India, and the number is growing. We are quite stringent as far as the selection of hospitals is concerned. We have got set of criteria, and we need a dedicated pediatric cardiology department with a dedicated pediatric cardiac ICU, an intensivist, an anesthetist, and so on. The sources of funds for Genesis Foundation are primarily the CSR, online sourcing, private donors and fundraisers, but the focus is now more into CSR. In 2014, Government of India had placed the CSR bill under Schedule 7 of the Companies Act. This slide represents the trajectory of our CSR growth. As you can see, last year we raised close to $1 million and we supported 600 children. Out of the 600, our success rate was about 99%. We lost 6 children. And 30% of our children were in the neonatal period with critical illness. This was a survey done by KPMG, which shows that last year the annual outflow for CSR was 12,000 crores. This is a huge amount. Education and healthcare, they received maximum funding. Unfortunately, in healthcare, it is more into the preventive healthcare, not into curative. This is because there is lack of awareness about CSD in India. So if we can, I would like all the people present here to have some CSD awareness program pan-India so that we can tap into this pool of CSR. Way forward is certain states in India have public-private partnerships, like southern states where they have government insurance schemes. So we partner with the hospitals wherein the state governments pay part of the funding and we pay part of the funding. In this way, we are able to treat more children. But this public-private partnership, there's a lack in the North India where hospitals are not willing to come forward. So it will be better if we have more hospitals in North where the burden of CSD is more. This is it. Thank you. Any questions?
Thank you, Doctor. Yeah, it was very helpful to be in time. Thank you. I have great pleasure in inviting Dr. Krishna Kumar, who is head of the Department Pediatric Cardiology and professor at School of Medicine, Kochi. He is speaking on sustainability in pediatric cardiac care, a call for collective action. Thank you.
Hello. Thank you, Ashish, for this invitation. And this is an unusual topic. It's about thinking for the future. And I hope to use this talk more to inspire than to inform. So this is my definition of sustainability. It's about thinking of the future in a pragmatic way. This is a quote that I found recently. So I'll just read it. Every profession bears the responsibility to understand the circumstances that enable its existence, that allow us to exist in the future. What are those circumstances? We have to understand and we have to then nurture those circumstances. I'll start with a experience that I had in Ahmedabad in last year's PCSI. Dr. Shaunak Shah, you were there? Yes. And I was speaking at the plenary that followed the inauguration. Now, today the inauguration is going to follow this plenary, but there it was the plenary that followed the inauguration. I couldn't take a picture of the room, but this is how it was. And I was talking about, the topic was given to me was tackling the biggest killer in cardiac surgery, which is sepsis. And I was asked to provide a roadmap, and there was nobody. There were like 3 or 4 people listening to me. And right after that plenary, I had to go and give a talk on closing the membranous VST with the ADO2 device, and this was how the room was. It was right next door. And it just got me thinking. Firstly, I thought it was me. I mean, nobody wanted to listen to me, perhaps. But then it wasn't the case, because I went to the next room and I found this, and there were people really interested in listening to what I had to say on an issue that I thought was nowhere as important as the issue I was asked to first speak on. And it was very disappointing initially. I felt quite badly for some time, but then I think it reflected and thought deeply that it's a very human situation. We tend to instinctively look away from unpleasant truths that threaten our future. This is very instinctive about all human beings, I think. And we are no different as pediatric cardiac professionals. We as human beings, as humanity, don't confront the truths, the challenges, the threats for our future. We don't think enough about our future generations. So if you look at core issues, climate change, and this is a picture from Kerala during the floods. And this problem was going to happen. And we knew it, and we ignored, and we paid a price for collective negligence. This is Tamil Nadu, this is Chennai, and this is the water scarcity in Chennai. And these are all pictures that are fairly recent and that affect all of us in our real life existence. And again, as citizens, very little collective action. Delhi, there's a lot you can do, all of us can do, and all of us can relate to this. This is hitting us on our face today. And this is a picture that I have taken, I feel strongly about personally in Cochin. It's the solid waste disposal. I feel badly about it every time, but I look away. I don't really take action. So we have a problem. We don't think, we can't act together collectively or individually about the future. So why should we be different as pediatric cardiologists? Now, of course, this is the core issue. The greatest threat of the planet is the belief that someone else will save it. And of course, I must congratulate Ashish and the Sai Sanjeevani Trust to do what they have done. And I think this is not just symbolic, what they have done. It's inspirational, and we should take back this as an important lesson for all of us when we go back to our homes. But then coming back to pediatric cardiac care, as pediatric cardiac professionals, it's surprising that we devote very little time and energy to address the greatest threats of our future. And I want to list those threats now. And I think you can add to that list. And I'll start by talking about what I think is the biggest threat. So I think the biggest threat is antibiotic resistance. I think if we go at the rate we are going, you will not be able to do infant heart surgery because you will not have the antibiotics to take care of your babies. And that's looming large. It's already there. We're already losing babies from multi-drug resistance, and multi-drug resistance is rampant, and antibiotic abuse is rampant. And all of us are responsible, not just the surgeons. The 3 threats, professionals that are really important for our care, and we don't do enough to nurture future generations. I think we do very little for nursing, and we can do a lot more. We haven't done enough to figure out how we are going to staff our ICUs. This shortfall of intensivists is going to hit us eventually. And I think the surgeons of the current generation and the immediate previous generation haven't done enough to try and create the surgeons for the future generations. Whatever be the reasons, we have lots of excuses, but we haven't had enough action. That's the hard truth. And then we need to think about our economic viability as a specialty. The costs of care are rising. We've had a very wonderful, inspiring talk on resource, the fact that material resources are finite and we need to be mindful of those resources. And I think we have to find ways to address that, and we haven't done enough about that. And also we have to recognize that public insurance is going to be the only way that care is going to be funded. And we have to find a way to really handle this fact that we are really compensated very poorly for the cost of care from public insurance, and we got to find a way to make the whole specialty, the whole endeavor viable. And then, of course, there is threats to our individual sustainability, which we seriously ignore, all of us. Our own health, our families, and of course, we all face a certain level of burnout. In some cases, it's very severe. In some cases, it's subtle, but it's there. So it's true, I think, that we don't do anything or very little for our future, but we need to think more deeply and ask the question, why? Why do we not look enough towards the future? And I think it's very human. It's very, very deeply ingrained within our psyche. It's far deeper than you can think. It's ancient. If you look at, we've got these reasons listed out, which is denial. I think some of us don't even think that it's a problem. We genuinely, we lack the ability to think 20 years ahead, 10 years ahead. All of us collectively, we can't think enough into the future. We want to feel good about ourselves all the time, and I think one way of doing that is to do procedures, whether it's interventions or surgeries, and you get that initial high of having done something, but then we really don't balance that with thinking about the future. And we are also too caught up in our day-to-day demands, and they're quite significant. So these are all reasons that we need to be mindful of, aware of, so that we can make the corrections. But I think to go a little deeper, we don't think about the future, and I think it's something that's really been chronicled in ancient texts. So this is Yaksha Prashna, which is from Mahabharata. And this is the story of Yudhishthira, who was faced with, in the enchanted pool, with this being, which is actually a enchanted being, a Yaksha, who asked questions. And there were 33 questions that were asked by Yudhishthira, and he had to save his brothers who were dead because they couldn't listen to this person. And the question was, what is most wonderful? And the answer really was very fundamental. Day after day, countless creatures are going to the abode of Yama. That means they're dying. And yet, those who remain behind think themselves to be immortal. What can be more wonderful than this? So this is deeply ingrained into our psyche. We just don't believe in our own mortality, in our own, the fact that we're going to leave this world. So we somehow don't really think enough about the next generation. So how should we go about it? How should we move towards a sustainable future? I think I'll start by saying that we need to think about it. And I think this conference, this forum, this society needs to do more. PCSI needs to do more towards making ourselves sustainable. We need to be thinking about it. We need to stimulate that thought. We need to talk about it amongst ourselves, discuss, then we need to do something. We need to inspire others who have not attended this conference. We make a difference and then bring about a transformation. That is probably what we all have to be doing, and we got to figure out the way, at least for the future conferences. So here are some suggested action items, and we'll go by one. I think I'll start talking about infection control. This is my pet area. I have been working for the last 20 years in my own institution. And it's one of those hardest challenges when you want to institute good infection control. That's the first step. Antibiotic stewardship is the second step. If you can have good infection control, the need for multi-drug resistance, the need for using high-end antibiotics would decline in your institution. And that's the first step, and that's the first battle. But the harder battle is antibiotic stewardship, and it really has to be a collective effort. We just do very little advocacy for our nurses. It's a fact. And I can say from personal experience, from my own institution's experience, that the single reason we got our surgical mortality down to 1% from 4 or 5% was empowerment of our nurses. That's my view. The single reason why we achieved infection control was the participation of our nurses. So they are the most important partners in our care, and we are really threatened by the fact that our nurses are leaving us in large numbers. They're going elsewhere because we just don't provide an attractive career option for them. And we have to be their advocates. There aren't enough advocates for them. They themselves are not able to advocate for their own cause. We do have organizations that are trying to do advocacy. It's not working. So we are much more powerful. We have a greater level of influence, and we need to do something about it. Then I think pediatric cardiac intensive care has to be created as a distinctly identifiable entity in our country. We've developed so far with pediatric cardiology and cardiac surgery, we've completely neglected pediatric cardiac intensive care. We have lots of excuses. We haven't done enough to nurture and create this whole cadre, which is critical to our future. We really need to do that. This has to be a recognizable discipline, and this needs to be made sustainable. Pediatric cardiac surgery has to be made attractive and rewarding. And I think what we are seeing today is because of the neglect 20 years ago, 10 years ago. What I used to see about the cardiac surgery training program when I was a fellow, that was the foundation of why we are in what we are today. Because the surgical residents were treated so badly, and their career options were so terrible, and nothing was done to nurture it. We are seeing what we are seeing today. So that's an issue that we really have to think. It's correctable, it can still be fixed, and we need to figure out how to do that. Partnering with Indian industry, I think we've started to do it. It's very exciting what's happening. I'll show you some examples, but we need to do that more. We need to have more affordable products that are for our needs. We can't keep importing stuff. So we need to do that, and that's happening. It's heartening, but it needs to happen more. And then we need to seriously engage with the government. We are disengaged with our government. We are disconnected with our government. We are disconnected with health administrators. We don't talk to them enough. We just keep blaming them. They don't understand us. We don't understand them. We don't understand how they function, but we are not having the dialogue. We are not having the crosstalk. And only then can we have rational insurance policies. We can have policies that make sense. We can't have the compensation packages that exist currently. So these are the things that we have to do as a society. This is the roadmap for our society, and we need to think about it. So here are the last point, which I'm sorry, I should go back to the last point. The last point, of course, very important, is what was outlined in the previous lecture by Kirk, which is responsible, thoughtful care of our patients with minimal wastage of resources. Now, this involves case selection, careful use of resources, buying the right kind of equipment, having some kind of audit on very expensive equipment that we buy, high-end equipment like, 3D echo, for instance. There was a nice talk on it, but I'm not particularly sure if it adds that value for the cost increment that you have. Or hybrid ORs, which do maybe 1% of the cases. There's lots of things that we need to think about collectively and individually, and we got to be doing that audit here in this conference. What are the differences, real true differences that these expensive technologies do to us? So we need to think about it. Okay, I'll just give you some examples. One example of a success story from my own institution is infection control at AIIMS in Cochin, where we brought about a radical cultural transformation. We got administration to be involved. We got the entire workforce motivated from within, and we put the empowered nurse at the center of the efforts. And of course, we were relentless and persistent. And because of that, we were able to bring down our bacterial sepsis rates from nearly terribly embarrassing 17-18% down to 1% in the 20 years that happened. So this is one success story, and that I think if we hadn't done that, we would have been destroyed by antibiotic resistance. Another success story, Nageshwar Rao is here. We've discussed this story. This is a beautiful example of a technology that has been developed within India, a product that is developed within India. And if somebody from Life Tech is here, got to make this affordable. Can't be expensive. It's now competing in costs with the other overseas devices because, it seems very you sort of an ego issue when you want to make it less expensive, but we got to make it inexpensive. Again, Nageshwar has developed this neonatal duct stent kit, the TTK Chitra heart valve. We got to be proud of this. This is an incredible product that we have produced. Then we have the implantable aortic valve that has been produced within India. So these are all examples of technology, and we need to move more towards these technology, nurture these technology, and develop newer methods to deal with it. So I think I'll sort of end towards with a ray of hope. I think there is hope for the future, because we as pediatric cardiac professionals are a group of people that haven't really gone along the stream. We've had more easy options in our life, we had more comfortable options, more lucrative options, and we've actually not gone that path. So there is hope, because we are a group of people who can make the change. We just need to wake up. And I'll end this slide with this particular presentation with this slide, with this quote from Margaret Mead, that never doubt that a small group of thoughtful, committed citizens can change the world. And indeed, it's the only thing that ever has. And it takes me back to 1997, when 8 of us sat in Dr. Savitri Srivastav's home and created the Pediatric Cardiac Society of India. Thank you.
Thank you, sir. Wonderful lecture. Just I want to know one thing, that if any pediatric postgraduate asks from me, what's so wonderful about having pediatric cardiology as a career? So what should I answer?
But the answer is, I think it gives you satisfaction at multiple levels. Pediatric cardiology is intellectually stimulating. There is infinite variety. No 2 days are the same. No 2 patients are the same. Every day you're stimulated. Everything is very exciting. And there is no end to academic pursuits. So that's the academic side of it. The satisfaction to deal with patients, their challenges, and the joy of getting to see a child get better with whatever you do is another reason to do it. And then, of course, it's very meaningful, because congenital heart disease is going to emerge as one of the major causes of infant deaths in this country. So there's lots of reasons to want to do it.
Thank you very much, Dr. Krishna Kumar. That was a wonderful finale to this thought-provoking session. I thank all the speakers for sticking to time. We are 20 minutes ahead of the schedule. That in itself is an achievement. I think the great takeaways would be, one is we need to find local solution to these problems. Second is we must have public-private partnership and doctor, bureaucrats and government partnership. And the final thing is all conferences must have sessions like this. To this, I would like to thank Ashish. Ashish, you have done a wonderful job keeping this session in the conference. And so we move on to the next, that is our interaction with the government, I think. So. All right, since we have some time and since Mr. Chief Minister is a little late, we will have this talk, Interventions in CHD under National and State Scheme, Pros and Cons by Dr. Muthukumaran CS, the Consultant Pediatric Cardiologist at Apollo Children's Hospital, Chennai. Dr. Muthukumaran. Please wait for this.
I just want to thank Dr. Krishna Kumar again, because he's taken me back to some 30 years back. We were still thinking about all these issues, and coming in the present perspective, it's again welcome.
One more thing, like about the schemes like RBSK, the problem is the government planning and the funding. There they seem to forgotten about the manpower involved in that care. So most of the time the funding is so less that viability seems very difficult.
There will be a 30 seconds video prior to the beginning of this talk. Just a 30 seconds video will be played now.
A coming together is the happily ever after everyone wishes for. But for the Mondals, their baby's struggling heart made it a distant dream. The Mondals are now busy creating new memories every day, like planning their first family vacation abroad. With life-changing solutions like occluders to correct structural heart defects, at Abbott, we are working to turn every tomorrow into a story of firsts. The most personal technology is technology with the power to change your life.
Very good morning to all. I thank the organizers for inviting me for this wonderful meeting. So I don't know why they chose me particularly for this topic. Maybe in Tamil Nadu we started this government scheme very early, like 2008. Maybe that's the reason they might have chosen me particularly to talk about this pros and cons. Quite a difficult topic to talk on. I'm just going to quickly go through my experience as such, what we did in Tamil Nadu when I started off in 2008, when I came back from UK, and how situations are there now in Tamil Nadu, and then tell what I feel as humbly what can be done to support the government scheme, maybe how improvements can be made in the government scheme to improve the life of all those children who have heart diseases. So this paper, many would have read Dr. Saxena's paper, very popular paper. The burden of congenital heart disease in India, you all know, is quite high. And I know that the vast difference in the amount of prevalence coming from north to south, east to west. But if you look at the birth rate, around 240,000 children are born every year with heart disease. And then if you look at the way people come to intervention, very minimal people come to intervention, which adds on to the prevalence of the heart disease in India. So the heart disease, actually the burden is quite a lot. But the problem we face is challenges is the late diagnosis. Most often we don't have a robust system of diagnosing them as early as the neonatal life, and the ignorance among the congenital heart workers regarding congenital heart disease. We don't have a lack of follow-up care. Patients don't turn up for follow-up care, and the mal-distribution of resources. Dr. Krishna Kumar said how the resources are mal-distributed. And finally, the financial constraints which are there as a big backlog for us to improve on the pediatric cardiac work. So, looking at the way the Tamil Nadu situation, when I started in 2009, I come from Apollo hospitals in Chennai. When I was there, I used to go for a camp. We do camps around Tamil Nadu as a free camp. When we go, initially we used to see around 1,000 children in a single day, which is sort of difficult to imagine, with about 4 or 5 people with 4 or 4 echo machines. And we used to get around 400 to 500 children with heart disease. And it's quite a sad thing to note at the time. And at the time we didn't have any support at all. We had no charity from the government, no other charities available, but Apollo had a Save a Child's Heart initiative, so we could only able to save a portion of the children of the heart disease. At the time, 2009, the government introduced this scheme where people under the poverty line can benefit out of it. You can see the number of surgeries and number of interventions progressively increased from 20 to 100 and 15 to 50 per month. And the centers initially started off in Chennai, about 3 or 4 centers. Now, all over Tamil Nadu, we have second-tier cities where the cardiac interventions being done. And if you look at that, 70-90% of our work is based on government-supported work we do. But the problem we faced is the amount which was allotted by the government progressively came down. Even simple procedures like ASC, VSC, PDA were difficult to do. And so that's what is the other side of it. So on the other side, what we face is steady decline in the number of paying patients. Everybody wanted to go to government scheme. So we had a steady decline of the patients who can come, affordable patients, which is sort of backbone for any program to run. The money allotted doesn't cover the entire expenses. For example, the money which is covered for a simple PDA doesn't give you enough money to look at your hardware, your wires and delivery system. Only the device is covered. Most often we are forced to use substandard materials, which really compromise the quality for these patients. And one more important thing I did face in my place is procedure done by untrained professionals around, I'm talking about people who haven't had to do with pediatric work, who started to do pediatric work, and the more complications happen, and devices cases, which are deviceable cases went for surgery, and surgical cases which are like clear-cut surgery had forced to have a devices. So those lot of things are going on here. No quality monitoring on the implants, which implants have been implanted. A lot of implants came into market, which one implanted, no quality markets, and no follow-up on these patients. So that's sort of an issue we had in Tamil Nadu, but we have a huge state, but considerable amount of improvement in the amount of decreasing prevalence has come down, but there's a wide variation of what's the quality of this treatment was existing in Tamil Nadu. So if you look at the broad all over India, look at the aspects of it, north and east, we can see quite a significant dip in the amount of congenital heart surgeries done within the first year of life. But south zone fares well because south zone was supported well by the government scheme initially. Although the government scheme is not that enough, we could be able to support the government scheme with other charities and be able to do a lot of surgeries around. And that's the reason our PM has introduced this new scheme, which is going to be all over India, where they're going to give 5 lakhs to like 500 million beneficiaries around India, where they can get treated for multiple problems. And one of the important problems is your heart disease. And it will be definitely a big boon to particularly states in northeast and west and north states. But in what way it can improve? I'm just saying definitely it's a double-edged sword, but I want, on one hand, it definitely helps us to serve more people, but we should have a way of doing it. So if I look at PDA device closure now, according to the package, 40,000 rupees, which I just want to just take on that as an example to show. So PDAs can be done in 3 different ways. Medical therapy we do in neonatal unit, but most commonly we close by device. Surgical PDA closure is very limited to very large PDAs and very, very small infants nowadays. Most commonly we do by device. And look at the cost involved in a PDA device closure, starting from outpatients to the follow-up. We have n number of time where lot of resources been given, but only one thing the government is worried about is the implant, the implant charges, and this one actually. So whenever they do a costing, I feel that we need to get involved so that we can have a clear-cut costing packages so that we can have for quality for all these patients and really affordable prices. So the package rate around India, starting from West Bengal to Rajasthan, you can see that West Bengal government gives 1,20,000 for a PDA, and then 30,000 in Rajasthan. It's got a lot of variation in it, and if you look at the graph, you can see how different it is. So where is this quality treatment arise? Wealth benefit for patient maximized at X or Y. Obviously, why? Because we will use lot of materials which is sort of standard materials for the patient. But we should have a midway in between where we can have a transparent costing, so that we can make sure that patient gets benefited fully by this package. And moreover, the devices also, you should need to look at the devices, the quality of devices, how committed and how well they maintain the quality. Those should need to be addressed. So the pros, actually, as I told, good. We are very happy that we had government scheme in Tamil Nadu because we did really bring the prevalence down. Now I went to a camp in Tirunelveli last week. We had only about 20 patients compared to 400 patients last 10 years ago. So there's a lot of decrease in the prevalence of heart disease. We only facing, I can say proudly that we are facing incidents only in Tamil Nadu now. This situation we want to go all over India, but the only way to do is the government has to support us. But how can we improve it, to give a quality care? I'm not talking about only intervention. For surgical also, look at the packages given by surgery is very, very minimal packages. And in a way that we improve the packages so that we can attract and give good quality for all those children. So if you look at the important thing, I would say that I want to address, lot of unnecessary procedures being done, and that's something we need to monitor, and there should be guidelines for this. And and we need to have diagnostic procedures being involved in these packages. Most often a CT scan and MRI or angiogram is not covered, and so we cannot plan the surgeries properly for these children. So, so in what way are we going to go forward? So we should have a standard treatment guidelines formulated by a body like us, like a PCSI, to see the right treatment for the right patient and the right hardware which should be used, and it should be given to the government saying these are the hardware should be used, these are the treatment modalities should be used, and the right patients. Centers accreditation. Every center is allowed to do pediatric cardiac care all over India. I just want to say that people should have a minimum number, like a person who is able to do this should be set by us, say, to do the procedures, so that the quality of procedures being done well for all these patients. People who have not done open heart surgery in a child is doing open heart surgery in center. I've seen that. And similarly, with people who are not doing any PDA, VSD closures, doing VSD closures, so we need to have a guidelines behind it. Transparent scientific costing methods. We should include all the hardwares inside, so that we don't need to use substandard reuse devices for all these patients. And we should look at long-term outcome, patient outcomes. We should have data being. Government should be able to pull out data from all the centers who are involved to show the outcome of all these patients, and to compare with other centers to formulate guidelines what is going to happen, because there's no long-term outcome data published by the government yet. So we have to look at this and see what is the best practice, and we should follow the best practice. And we should also cover the diagnostic procedures before the surgery, making sure we do the right thing for all these patients. And thank you for listening. Thank you.
Thank you very much, Dr. Muthu. Very, very well presented facts. I can say that public-private partnership was a wonderful idea, but now it's like a swan without its robe, where you see that it's a beautiful thing that government is sponsoring so much. But the thing is, if you are thinking of device, you are not having money for the delivery system. You are not thinking about the infrastructure investment of a private setup. You are not thinking about the doctors, sisters, and the all intensive care, this thing. So, I mean, it's initially when CGHS schemes started, then probably it was 50% of the original package they asked for. Over the period of time, cost of investment increased, the salary of expected salary of a person is increased, but the government, what they did, they bring down more and more diseases inside it, the more like non-government people also into it, and they kept on keeping budget same and decreasing the prices and packages, which is not practical at all for a quality care.
Exactly.
So I think their advocacy is needed, that at least a practical, realistic approach should be there, so that these public-private partnership can work at a realistic level. Otherwise, you are right. There are very many procedures are being done which are not required. So that is how it's happening.
No, actually, if you look at the way the procedures take along to everything, the cost has increased. The only thing I'm seeing is the cost of medical treatment is coming down. Everything else gone up. If your dosa has gone up, your idli is gone up, whatever you want, everything is gone up. But when you look at the cost of treatment of the important congenital heart disease, I would say we start off 1,20,000 rupees for a VST surgical closure. Now they give 74,000 rupees, which is, I don't know how we're going to manage that. The ICU, the nurses, the setting, I don't know. And also the important thing is, I want them to target on disease base rather than, that package base. VST device closure, VST surgical closure for a 3-month-old is different from a 5-year-old. But they don't differentiate that. So you should need to have a system where we can all have a close tie with the government to guide the government, so that we can effectively give this treatment for all these children.
And not only that, when you read the paper, what they send, you have to collect patient from the railway station and you have to leave them there. And you have to provide the diet for the attendant also, and their stay in the hospital. So.
Well, one more thing what I see is there is no unity among us as people. If I would not want to give accommodation and food, some other hospital gives it at expense of something else. I think as a group of clinicians and pediatric cardiology, we should come together and say this is what we need, a basic requirement to really tackle the difficult problems. And I just feel that the unity should be among us first.
I'm not a spokesperson for the government, and I know nothing about this. But what I want is that as primary care physicians, we also need to educate the communities who are the beneficiaries. They must know what's happening. And I will just give you an example of rheumatic heart disease. There were children, just because the government is helping, the parents are keen that you operate. Many of them can wait for the surgery because the cost of and the effects of putting a prosthetic heart valve where you can repair or wait are definitely need to be explained to the relatives, and don't rush in for unnecessary procedures.
That's why I mentioned the unnecessary procedures.
The recent RBSK package for balloon mitral valvotomy is 30,000, where the cost of Innove balloon is 1,10,000. And on the other side, we have a government regulation for not reusing the balloon, which is a disease of a very poor man. So how do we do that? Now, Bombay, even the public hospitals have stopped doing balloon mitral valvotomies. Where should the patients go?
Do a closed mitral valve.
Yeah, that is another thing. Do a closed mitral valvotomy. But this is a thing which is, and another thing, our neonatal balloon valvotomies, the cost is like the cost given by RBSK is 30,000. Our Taishak balloon costs 50,000. We have another hardware. I don't know how do we do that. And many centers have stopped doing because it's just not possible to do in the.
I think it is very important, and the way to start, I believe, is to have our own textbook of pediatric cardiology and pediatric cardiac surgery, just the way the API has. I'm sure you are aware there is a API textbook of medicine. So with the volume of work that this country is doing, and with stalwarts all around us, I think it is time to have our own data textbook, and then pressurize the government into doing what we want to be done. I think.
I just have to see one thing about cost. I'll tell you, personal experience. Because I do a large volume of repair work. What happened is they set the price for valve replacement, and TTK valve was the same, so they could negotiate the price down. But the problem was that the rings were extremely expensive. So finally, what we had to do is call them and tell them, if you the various companies, and told them you have to bring the price down. And we started negotiating with them that if you don't, see, sometimes we need to, see, we are bad negotiators as cardiologists and cardiac surgeons. We don't negotiate properly. So we told them, say, we are doing 200, 250 repairs per year. If you don't reduce it, we won't use it. Then I make an indigenous ring. I said I will shift back to the indigenous ring. So then, they broke. So one company brought the price down, and now we are finding the other side. Where was the money? Why? How are they able to reduce the prices? It's not just saying that the costs are, the prices of those devices are not necessarily as expensive as what we think they are. The problem also on our side is we are bad negotiators. We have to learn to negotiate too.
This was indeed a very interesting and informative session. Healthcare funding has become such an important topic and priority today that many institutions are bringing out courses for training health professionals in this particular topic, health management professionals for this particular topic. So I thank the moderators for chairing this session and the speakers for their insightful talks. Thank you, sir. Thank you, ma'am. Thank you. Yes. In view of the security arrangements that are required for the Honorable Chief Minister of Chhattisgarh for the inaugural function, we shall now have a break for 10 minutes. Ma'am, please. Some important announcements. Poster session has been arranged in the lobby next to Dr. Dolly D. Hansen Hall. There are some other important events that are also arranged alongside the conference. Shrimai Braveheart Woods tree plantation is held parallel to the conference and will be held through the day. Those interested may please get in touch with volunteers at the registration desk. Again, a reminder about the general body meeting of PCSI this evening at 6:30 p.m. on first floor in this edifice. Then the gala dinner and cultural program from 8 p.m. onwards, again in the sacred space on first floor in this edifice. An exciting 5-mile run tomorrow early morning 5:30 a.m. to 6:30 a.m. requesting all participants to please reach the venue by 5:15 a.m. Transportation to and fro from the venue and the hotels has been arranged. And blissful heart yoga sessions by Yogi Ji, Mr. Richard Gorel, will be held from 6:30 a.m. onwards, again in the sacred space, first floor in this edifice. We shall now have a break for 10 minutes, followed by the inaugural session of 20th Annual Conference of Pediatric Cardiac Society of India. Chief guest is Chief Minister of Chhattisgarh, Shri Bhupesh Baghel ji. Thank you.